Uh, Good afternoon, everyone. So now you have heard from Shane about all good things. I am the bad man here. So let's look at all the complications regularly that we see with intravitreal slides. So. Let's do a case-based discussion. So our first patient is a 60-year-old man who has occult CNVM with good. But after 1 month, oops, the vision is 3/60 now, and we can see a very large RP rip under the macula, which is a very well-known complication of pigment epithelial detachment, CNVM. So in this situation, if the disease is active on so again a submacular hemorrhage associated with probably a PCV, polypoidal choroidal vasculopathy here, and anti-VEGF comes with a hand movements vision, and we have a massive breakthrough vitreous hemorrhage with a suprachoroidal hemorrhage as well. So breakthrough vitreous hemorrhage in a PCV can be a complication following anti-VEGF therapy, and patient underwent vitrectomy and silicone oil, and half by 60 vision was recovered. So the third case is a 67-year-old male, a defective vision 2 weeks and 6/18 vision. You can see this irregular PED subretinal fluid, some fibrin here, and thick choroid, and OCT and ICG FFA shows the ink blot leaks here, but here, patient was started on ranibizumab monthly injections. After 3 monthly injection, truly non-responder, so shifted to aflibercept. But still, here we have a paradoxical increase in fluid and PED. So sometimes after switching to a better anti-VEGF or a potent anti-VEGF, you can have this paradoxical response, and finally had to do with a combination treatment with PDT, photodynamic therapy, and in combination with aflibercept. So paradoxical response also worsening can also be seen with anti-VEGF injections in PCV CNVM context. So now let's look at diabetic retinopathy. Protocol S was a comparative trial looking anti-VEGF injections as a alternate. So, some of the case examples here. This patient, severe NPDR, early PDR, this flat NVE or flat fibrous problem was missed in the initial. After the injection, this is after we can have this angiofibrotic switch, or we call it a crunch phenomenon leading to tractional retinal detachment. This is again prior to the vitrectomy, this very vascular surgery. Avastin was given intravitreally, but ask the patient to come after 4 days for surgery, but he comes after 2 weeks. See, all the vessels are occluded. We have a very fibrotic membrane, tractional retinal detachment, vision has dropped to hand movements vision. And after vitrectomy and timeline, after 2 weeks, what happens after in a PDR situation? You have to be very careful in giving anti-VEGF therapy for PDR, because this crunch effect takes 2 weeks to form the tractional retinal detachment, and it happens in around 5% of the patients with PDR. So it has to be kept in mind, because the anti-angiogenesis takes only 4 to 5 days, not more than that if you want to operate on a highly vascular PDR case. So if you are using anti-VEGF as an alternative to PRP in PDR, has to be very diligent follow-up, because 1/3 of the patients, if lost to follow-up, can come back to you with neovascular glaucoma or advanced PDR. So another patient with central retinal vein Patient was underwent multiple intravitreal injections. As you can see, after 6th injection, it has settled down. But after 6 months, the macula is very dry and flat. There is an RP atrophy. So this is also a known complication, RP atrophy, following multiple anti-VEGF monthly injections. As you can see, you have a dry macula, but you have a macular atrophy. So in 7-Up study, after Anchor, Marina, and Horizon monthly injections, it was seen that using a fundus autofluorescence, almost 98% of the patients after 3 to 4 years of anti-VEGF therapy had some sort of atrophy at the macula. So this also has to be kept in mind when you're putting the patient on anti-VEGF therapy. So another aspect which already touched upon by the previous speakers is a non-resolution with anti-VEGF therapy, intravitreal injections. For example, this PDR patient post-PRP, there is a chronic DME of 2 years. After 3 Avastin monthly injections, shifted to Lucentis, shifted to aflibercept, it's still non-responder here. So in such situation, this patient had to be switched to Ozurdex injection, multiple Ozurdex also done a targeted PRP in a PDR setting. If you have a chronic DME, then better to target the CNP areas on wide field or ultra wide field fluorescein angiography to cover the CNP areas that are still skipped during the previous PRP. It might settle the macula. So macular edema. So the last case here, we have a young lady who has cardiomyopathy and history of blood dyscrasia. The picture was something like a BRVO in both the eyes with subtle submacular detachment here. So this patient, because of the history, we sent for a physician clearance, and patient came after 2 weeks. The submacular detachment has worsened, the vision has dropped to 5/60 and 2/60, but the blood report showed multiple myeloma, elevated protein fractions. This is not a vein occlusion, this is the venous stasis retinopathy in both the eyes because of the elevated proteins in the blood. So systemic status, why more than a hypertension or systemic disease, has to be kept in mind while putting the patient on anti-VEGF therapy. The other systemic issues have to be kept in mind: a recent cardiac or a stroke history within 3 months, and even after injections, multiple anti-VEGF injections, you're starting for first 2 years, for example, the stroke or MI has to be kept in mind if the patient is prone to it because of systemic status. So the miscellaneous or other causes or other complications where it can go wrong is endophthalmitis, especially with Avastin or intravitreal triamcinolone, and you can have sterile vitritis, which has been earlier reported with biosimilars and now recently with Peginax also. And then we have glaucoma, especially with Dexemplant or IVTA, and the procedure related, what it can go wrong is a lens touch during the injection procedure. So thank you all for your kind attention.
Thank you, sir, for this very pertinent talk on